that kitty video y'all saw. What's that little girl's diagnosis? What did she say she had? Leukemia. Now, what were some signs and symptoms that you heard? Bruising, fatigue. Yeah. What'd you say? Yeah, fever. Yes. So bruising, fatigue, and fever were kind of the main ones, weren't they? And why do you think, what may you see on her blood test that could be at least contributing to the fatigue? Yeah. Does anybody know why you can be anemic when you have leukemia? What kind of cells are abnormal in leukemia? Does anybody know? It's actually white. Leuco means white. Yeah, and erythro is red. So erythrocytes and then leukocytes. So it is actually white blood cells. And we are going to use that as that's an exemplar actually in 211AB. So we'll go in more detail with that. But this, since we're talking about generalities in cellular regulation at this point, that some of this can still apply. So when the bone marrow is just putting out so much white blood cells, abnormal white blood cells, then why do you think that the red would be low? Yeah, it's crowded. It's crowded out. Absolutely. That just makes sense, doesn't it? It just makes sense that it's so busy making, the marrow is so busy making white blood cells, that then what else might be low? The red blood cells can be low, but what else might be low that might cause her to bruise? Yeah, good. See, y'all are getting some of that with doing is probably. I think some of y'all are putting this together because you've looked up some things for clinical, haven't you, for abnormal lab values and all, and so you're starting to, you do get some content from doing your clinical lab interpretations, and that's going to help you a whole lot on NCLEX to be able to put those things together. Well, what do you think was going on with the little bully?
Lack of knowledge.
Yeah, he was ignorant, wasn't he? He just didn't. But when he found out, what happened when he found out what was really going on?
He felt bad.
And he complimented and felt bad and all that. And Linus kind of exploded, didn't he? I'm not sure if that was really appropriate behavior, but that's what he was really feeling, though, wasn't it? He was very angry. He was sad. He was angry. You kind of saw those stages of grief in Linus, didn't you? I mean, you saw he was angry. He was sad. He was depressed. I mean, it's just. And shocked, you have the shock and disbelief kind of thing. So and then they finally kind of get into this acceptance that this can be treated and things are going to be okay. So it really does show you those stages of grief also. And why do you think in the first place that the little bully boy acted like that?
Because he'd never seen it before.
And you said that the lack of knowledge and everything, but it's like when somebody's different than you are, sometimes it can be threatening, and it makes you feel a little powerless. So you want to try to exert the power on somebody else so that you can feel more comfortable in the situation when it's something strange, because that was a different thing that had ever seen before, and he may not have really intended to be mean, but he was sort of just meeting his own needs at that particular time. Okay, what about the siblings?
Jealous. For the attention she was getting.
Yeah, she was getting so much attention and lots of presents. And most of the presents that we ever get at our house are just for her. What's so great about her? But that is so real. It's so typical. And that it's I think it's just one of those. I call it green monster or whatever, but I think it is one of those things where it seems like an injustice in a way, but then when you really look at what's happened, and the little girls did say, well, it's probably because people are wanting her to get better. One of the sisters said that I think that they're giving her presents to show that they care about her and want her to get better. But it does really it's really sucks all of a lot, or maybe all of the energy out of the parents to be dealing with it, and so the parental attention is another thing that they don't get. It's not just presents and everything. We don't really see in the Peanuts kind of cartoons. We don't see how adults feel or whatever, but that's a whole different ball game there. But I just think that's a really, really good cartoon. I've never seen a Charlie Brown one that was that kind of serious. Had y'all ever seen that before? It was really, really old. I mean, obviously, because by the cartoon, you know, the commercials and everything. But and what's the guy's name that's in the How I Met Your Mother? Or he was in that big Purple People Eater. Did you see it when I was flipping through? That it was, what's his name?
Yeah, the Doogie Howser guy.
Neil Patrick Harris, that's him. Yeah, and he was Doogie Howser MD and all that. That was even before Doogie Howser MD. He was just like 10 years old or something probably there. So you can kind of tell how old it was. And I used to take everything. When I'm a terrible person to do technology or understand it or whatever. We got our first VCR, Sarah was 2, and we got the Disney Channel for $10 a month. It was a separate thing. You didn't have these packages or whatever. And I just taped everything off the Disney Channel and off of TV whenever the Charlie Brown specials would come on or any of that. I've just got hundreds of hours on video. And I just put a video in the other day of the Miracle of Life to put it to show y'all about some cells and things and it broke. The end of it broke, and I tried to tape it, and it still wouldn't go in the machine. But I looked on YouTube, and you know, technology can be a wonderful thing when people pirate stuff to YouTube that you might need in class because your video broke. So anyway, the technology can be your friend a whole lot of times. You just don't let it get to you. And that's when I get the angriest is driving my car and having trouble with my computer. That's when I just lose it. So I hope I won't lose it today. But if the YouTube is down, I might. But okay, this is really a kind of a jump. I just think this is a little easier to start with, and then we can kind of flow to the cancer. The cancer stuff is a lot more information. So let's go to our hematology, and I don't like this Turner thing, but I guess this is what we have to use to get it to go forward and backwards and all that. But okay, so backwards is forwards and forwards is backwards. Okay, I have to always remember that. All right, so you're going to see different ranges in different sources when you're looking at numbers of like normal numbers of white blood cells. Some of the lists say like 4,500 to 11,000. But the one that I'm using is 5 to 10. It's going to be close. We're not going to give you any kind of questions or anything about, you know, if it's 10,500 or whatever. That's probably the normal range on some of the machines, the way that they're calibrated. So we're not going to give you anything that's that fine a difference. But this is going to be all about blood cells. And so what does hemat mean? Or blood, yeah. And it doesn't just mean red, but that's mainly what our exemplars are going to have to do with. I guess I really ought to cut this down or off or something. Let's just see what works. Is that enough, or should I cut them all? Just do it all? Both of them? Is that too much? Oh, yeah. We got enough for... What's that? Somebody holler if you're good. All right. So, okay, 50 to 70% are the active phagocytes. What do we say phagocytes do? We talked about that. Yeah, they look like Pac-Man. It just eats it up. It gulps and eats it up. So, anyway, it is the lifespan of the neutrophils. These are really important when we get to the cancer part. The neutrophil part, or the polys, or the segs, is what you might see on your CBC. They are the first on the scene phagocytes. Now macrophages come later, and they're bigger cells. They have to be signaled to come. But the sentinels of the immune system are the neutrophils. So anyway, those white blood cells only live about 10 hours, and most white blood cells live only about 10 hours if they're the phagocytes. So that's a very, very short lifespan compared to red blood cells, isn't it? I know y'all studied that in the diabetes unit because it had to do with your E1 A1C, didn't it? Mm-hmm. But anyway, that's really, really important to know that it is a short lifespan. People can really drop quickly in the white blood cell count, especially the neutrophil count. But then once they start to regenerate, they can recover just really quickly and may even go above normal because the body's overcompensating to sort of a rebound effect. So anyway, that's what we difficult to deal with. We're going to work with this WBC differential in more in 211AB, but I just want you to know that when you're looking at the percentages, you've seen those CBCs and you've seen like where the white blood cells are high or low. Most of our clinical patients have been high because they've had pneumonia or infection or some kind of stress on their body and they've been high. But we're more concerned about whether they're low in a lot of situations with like cancer treatment. But anyway, when you see all those components like the neutrophils, the melanocytes, and the lymphocytes, and the basophils, and all that, eosinophils, all of those percentages should add up to 100%. Just so you know, if you see those percentages on your differential on the white blood cells, all of those together should add up to be 100%. And we'll do some math like that for the 211AB test, but that's not. I think I might have that in that. I think I have that on those math questions that I gave you, how to add that up. But that's not something you have to do now. Just know that all those percentages add up to 100%, and it should be about 50 to 70% of the neutrophils or polys. Okay, so how long is the lifespan for red? 120. About 120. Yeah. If they're normal red blood cells, we have some issues we may deal with here in this document. And I did change what I had from last year because your Iggy book gave just a little bit different ranges for the male and female. And again, it doesn't have to be just exact. But I think I had 4.7 to 5. What it said Iggy, but I had 4.5 to 5. I mean, it's really close. So just have the idea of the range. But the woman has a smaller amount of red blood cells, and the normal hemoglobin range is a little bit lower than it is for the male. Do you know why males have higher hemoglobin normally than females do?
Testosterone muscles.
Well, what causes those more muscles, and what causes more? What's different about men and women?
Testosterone.
This is hormone. Testosterone, yes, sir. Oh,
Female.
Just so you know, just right out of college, I worked on a general surgery unit at Duke, and they did kidney transplants. And we had, it was just a regular unit with like, I think it's 39 beds. We had like perpendicular halls, but the rooms that were kind of closest, we had 3 rooms close to the nursing station at the juncture of the 2 halls that could be used as like a one-on-one kind of ICU room, and we would actually get some overflow from some of the critical care units, like thoracic surgery sometimes, but we would get we got all the kidney transplants. So they would set it up, they would reserve one of those rooms, and the clinician that worked with the surgeon would set the room up and everything for us to be able to take care of one-on-one. You have to do just at least hourly output, I know, and just it was really intense and the clinician guides the care nurse through the whole process and everything. But one of the things that you have is a problem with, well, why would you have a kidney transplant? Renal failure, yeah. If your kidneys aren't working and you're dependent on dialysis, and you are healthy enough to have a transplant, and you have a donor that matches well enough that you can have a transplant, then that's the candidates that we would be looking for. So what happens though to red blood cell production when when kidneys are not working right. Yeah, erythropoietin, and I know we're going to get to that, but that really is an issue. Then, and we'll talk about that. That's the hormone that stimulates the red blood cell production, and is produced in where?
Bone marrow.
In the kidneys, but it stimulates the bone marrow, but it actually is produced in the kidneys, and it does stimulate the bone marrow. And again, I'm getting ahead of myself, but it does talk about why the men and women are different deal. What we would do with post-transplant patients that were still anemic, that since we have a 120-day lifespan of red blood cells, they don't produce really quickly in the bone marrow. It's just a slow, steady process to replace, since they live that long. But now the white blood cells turn down. So it's not easy to catch up when you are already anemic, right? They didn't have erythropoietin shots back then. So what they did was, I remember this one woman in particular, she was an older woman, like postmenopausal. Well, maybe not quite, but she probably lived all to me because I was just 21 when I started on that unit. But anyway, she had to take testosterone supplements. I can't even think of the name. It starts with an H. Halotestin, that's what it was, halotestin. And that's what we would give the men and the women to rev up their erythropoietin production, because that's testosterone does do that, does add some, and I guess it is to fuel those muscles that the men have extra muscle tissue and all that sort of thing, women have fat and all that. But I think that's just really interesting. Well, when she came back for follow-up, usually they would come and see us on the unit when they had their checkup, and she had a little beard, and her voice had gotten lower, and all those kinds of things. That I'm so glad we don't have to do that anymore. We have erythropoietin shots that we can give, but that's what we used to have to do. I mean, it worked, but it was at a price, a real body image price. Okay. So let's look at our platelet cells then, and their lifespan's about 10 days. So we got 10 hours, 10 days, and 120 days that we want to pretty much keep in mind. So the platelets are sort of in between there. So do know at least close to those values, so that you'll know what's going on. Now there is in your in your maternal child book, there's some blood results and everything for infants and children and all that sort of thing. And I think it is in some of the readings that I gave you. You don't have to memorize that, but you can kind of see how it, just sort of see the progression of it and how it changes through the lifespan of the child. Okay. So something, I need to get my little model here, but red blood cells have no nucleus if they are mature. If you have nucleated red blood cells, you may see that on your CBC in RBC. That means that they're not mature, and so that they are supposed to be. They are just these little discs. There are some cough drops and candies that are made like that. You've probably seen them like that, where they're sort of flat, but then they're kind of dipped in the middle, and that's what the normal red blood cells are supposed to look like. Why do you think they look like that?
Carry the oxygen.
Because what?
Carry the oxygen.
And they're malleable. They can fit into those tiny little capillaries and exchange oxygen. Exactly. That's exactly right. So, and that's what your notes page says there. And this Morris doesn't call me with all my notes yet, so if she comes in here, make sure you can see. But I just want to y'all to, there's so much in here, and I want to try to tell you what you need to know when you see it. So, but anyway, so our hemoglobin is in those red blood cells, and that carries our oxygen. We kind of talked about that some earlier in last semester somewhat. But anyway, if you do have an abnormal number of red blood cells, or if they are not shaped like that, or if there's not enough hemoglobin, or if there's too much hemoglobin content, then that can cause problems. So, and we talk about the surface area of the cell. That's what's going on. We are going to be talking about sickle cell in 211AB. That's going to be one of our big seminars. It's very, very, very interesting. So we're not going to go into detail about that now, but that's certainly different shape that we will be talking about. This is not a guarantee, but you can kind of expect if your patient gets a red blood cell transfusion that if things are going the way they should, and you take another CBC soon after they've had their transfusion, you would expect it to go up about 1 point unless they're like actively bleeding or something. If it's sort of a just slow, like a GI bleed, just slow ooze of blood in somebody's head, some blood loss that way, then you should really see it that the hemoglobin goes up about 1 point. So if they were 8 hemoglobin when you gave 3 units of red blood cells, then it would go up to 11. It should be about 11. And that's not a hard and fast, but that just gives you kind of an eyeball idea of what should go on. All right. This actually ended up, this is an Elsevier picture I've been using for several years, and we weren't using Elsevier textbook, but I love this picture. And it's actually in the cancer unit information now, but this just shows you different shapes of cells and how different it can be. This is a neuron, they look like stars, and then a skin fibroblast looks like a tool or something, or a saw or whatever, and then there's our mature red blood cell with the disc. So they call that the shape and the size morphology, and that's and I guess that makes sense. We talk about morph, that things are morphing into something else, and that was always the big thing with my kids was things morphing into transformers and all that sort of thing. So y'all probably are very familiar with that vocabulary, aren't you? So the stem cells that can become any cell in the body end up morphing from just a plain old cell into those kinds of differentiated shapes to be able to perform their particular functions. So that's just kind of comparing what the red looks like. Went the wrong way. Okay, sometimes it doesn't look good. There we go. All right, I like this one too. This is types of blood cells. This actually came from your maternal child. This is a Pearson slide, and it's still in the book. Can't remember where I saw it, but I know it's still there. And here's the granules in the cytoplasm. That's why you call them granulocytes a lot of times. That the neutrophils are granulocytes because there are granules in the cytoplasm, and then the eosinophils have granules as well. So here, that's a basophil, there's a neutrophil, that's a granulocyte also, and then that's a monocyte, which will be a macrophage. But the side view, here's the front view of your cough drop looking shape or whatever, and then if you look at the side view though, it obviously looks like a bone right there. And here's abnormal ones. There's sickle cells. You may see this on like some of the narrative on a CBC when they are doing the differential and they look under the microscope. The pathologist may put poikilocytosis. That means it's abnormal shape, and anisocytosis means that they're not all the same size. They should be all the same size. And then your platelets are fragments of the megakaryocytes. So we'll talk about that a little bit more, but that's just a microscopic appearance kind of thing. Okay, this is the right one. Oh, I love this too. I think this is very cool. This is a blood stem cell. This is not a embryonic stem cell, but there are blood stem cells that are in the bone marrow, and they are called pluripotent, meaning that they could become a number of different things. That when they're stimulated, they can differentiate into any of these cells that the body needs. So, and I think we talked about this before, that they can take blood stem cells and take them back a notch. They're trying to do that in the lab. Well, they developed that process because there was a ban against it. It was not lawful to do embryonic stem cell research for a while there, and that's still an ethical issue. But anyway, you can go backwards and make these stem cells even more primitive to where they could become any cell in the body. So that is possible with the technology we have now. I don't know how they do it, but they do. And here are erythroblasts. This just tells you what the the immature ones are. The stem cell goes to the erythroblast, and then the white blood cells are myeloblasts, white and red go to this. Then mono, lympho, and megakaryoblast. Megakaryocyte, and then you see the little granules that are the platelets or the fragments of that megakaryocyte. The one that I want you to really note for our intents and purposes right here is reticulocyte, because these are the ones that are they can carry some oxygen, but they're not as efficient as the mature red blood cell. If somebody has had a lot of bleeding, then sometimes you will see a lot of reticulocytes, because the bone marrow is trying to catch up with and replace, even though it is a slow process, it is trying to go ahead and put these out there to at least have some function so that it'll carry some oxygen. And you can kind of see right here, there's a nucleus still here, and this normoblast, and that's erythroblast. You've got nuclei there. And then these are your white blood cells. So, and I guess we had, the other thing about this one, the bands, we will talk about that when we're talking about absolute neutrophil count. That is a way that we can decide if somebody's okay to take chemotherapy or not, and we'll be talking about that more in 211AB. But the band cell is an immature white cell that sort of it can perform some of the functions of white blood cells, sort of like the reticulocyte can for red cells. So those can be. That's not horrible to have some of those, but if it's anything, there are several really steps in between here that they're not there. If they're more immature than the band cell, then it may end up being that there is a leukemia issue going on or some other abnormality. So anyway, the biggie, I want you to remember this on this slide or on the notes page is, of course, we talked about erythropoietin. It's this hormone made by the kidneys that causes the bone marrow to produce red blood cells. But the process is erythropoiesis. So erythropoietin and erythropoiesis. So those are very similar words there. And it takes the stem cell to about 3 to 5 days to go, once it's turned on by the erythropoietin, it takes about 3 to 5 days to produce. The real big thing there, and I've got it all underlined and bolded and everything. The stimulus for red blood cell production is not low red blood cells. What is it? It is a response. The erythropoietin is produced in the kidneys in response to tissue hypoxia, the tissue's need for oxygen, and that's what stimulates it. You're going to have low red blood cells in some of those processes when people have tissue hypoxia. But I know my clinical group has had lots of COPD. How many people have had COPD patients so far? I bet about half of you at least have. Or it may not have been their major diagnosis they came in the hospital with, but they've had it. A lot of people have it. So what do you see? How does the body sometimes compensate for that problem with oxygenation? What can happen with your red blood cells to compensate? Most of my clinical group knows that, but increases the number of red blood cells, and we do see people that are having like women may have 18 or 20,000. Or not 20, but 18 to 20 hemoglobin is what I'm saying, not the red blood cell count itself, but that hemoglobin could be as high as like 18 or 20 in some cases if the body has compensated for that. So that when you see a COPD patient that's anemic, then what are you going to worry about? Hypoxia, because they don't have that compensation going on. So they really, and I know y'all talked through Ms. Walker and everything with her unit. What if somebody's got COPD and they're anemic? Are we going to just slap 10 liters of oxygen on them? And so that's a slippery slope, isn't it? So those people are in some deep trouble. It's not a good thing. So really consider that. If you've got a COPD patient and they are anemic too, you've got double reason to worry about perfusion and hypoxia. So anyway, and then of course we already talked about the kidney disease and all that because of the erythropoiesis, and I got ahead of myself. We talked about 120 days and the hemoglobin A1C. Well, what happens if somebody is real anemic or they are experiencing a lot of red blood cell destruction? Maybe what are you going to do about trying to measure people's blood glucose control? Did y'all talk about that? If somebody didn't have normal
They're like
hemoglobin?
another test or something.
Because you have to. I don't even remember what you call it, but there is some other things you can do, but it's more expensive and all that kind of thing. I can't remember what it's called, but you do have to do that. You can't rely on the hemoglobin A1C if somebody's real anemic. That's the main point here. So. Anyway, our spleen is the organ that filters out the old cells and tries to recycle most of the components of the old red blood cells. Some of it does get it does get excreted through the GI tract after it's gone through the spleen and everything. But the body does try to recycle the iron and the other components of the red blood cells, amino acids and the heme and all that. Yeah, what happens when people don't have spleen? What's that? The other components in the lymphatic system try to do some compensation, but now the immunity part and everything, you do lose immunity to some things if you have vaccinations and all. You end up having to take more vaccinations again so that your body can produce the antibodies. Because the spleen is real critical for that. But yeah, the other components have to work harder. And it's not ideal, but you can get by without the spleen. So okay. Okay, if you do have a whole lot of destruction of red blood cells, then or the liver's not working right, then the heme, which is part of the hemoglobin, can, from the breakdown of the old red blood cells, it can actually just circulate in the bloodstream. And what color does it turn you? Yellow. Has anybody had a jaundiced baby? I had my baby, my first one was. And then did you have to use the Billy light? Oh, that's what they ended up doing. Yeah, Sarah was just like 9 days old, and it was really dark and rainy and then hurricanes and all that kind of stuff. So it was just we didn't have much sunlight, so they made us stay in hospital. And at that point, they didn't do that anymore. They really like calm down.
How many?
But they had her in the Billy light with nothing on but sunglasses, and then told me once the sun came out that we'd go home and put her in her dry freezer and that's the way to get her moving now. How newborns don't, or how come newborns do have bilirubin in their blood? Yeah, the liver's immature and it can't handle all of the breakdowns. And why do they have a lot of breakdown when they're first born? What's that? Why do newborns have a lot of red blood cell breakdown right after birth? What'd you say, Jim?
Because they've been using their mother's circulation.
Yeah, they've been using their mothers. That's exactly right. It's kind of second hand, isn't it? The oxygen has to come second hand into the baby's body, and it's not as highly oxygenated by the time it goes through the placenta and everything. And so the fetus has to have more red blood cells to be able to carry the lesser amount of oxygen than what the mother had originally. By the time it got there and got to the baby, then the extra red blood cells are making the process more efficient, even though they don't put oxygen in the baby's blood as they're in the mother's blood. It's sort of like what happens with the COPD patient. It's a compensation sort of thing. And so as soon as the baby starts taking its own breaths, though, it doesn't need all those red blood cells, and so they are destroyed. And when their little livers are not ready to take care of that, then there can be a buildup, and if they're a little bit immature. So I think that's pretty cool if you've experienced that yourself, or you know somebody that has. It's pretty neat concept. All right. Let's see if I can get this to you.
Miss Baker.
Okay.
I'm
Yeah.
confused on something.
Uh-huh.
You said with COPD and they can't compensate, so they like have a problem with the red blood cells? Or that's not what you were saying?
Oh, if they have COPD and are anemic, they're not able to compensate because the compensation would be that they have more hemoglobin like the fetuses do. But if they don't have a high hemoglobin, they're really that's one compensation thing that they're not able to take advantage of. So does that make sense? Okay, and I'm not going to really test you exactly on that, but I just think you need to understand what's going on, because you're just going to see lots of COPD patients, and y'all going to be going to B this summer, and you're going to experience some of these things, and I want you to understand what's happening, instead of just, okay, this hemoglobin's this and blah 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 blah, and they're jaundiced, and not understand the connection. I want you to be able to connect it. All right, this is just a FYI. You don't have to memorize this at all, but I just think it's really cool that here's our plasma, and then our formed elements, which is the cells, your platelets and your white blood cells and your red blood cells are the formed elements, and then you got plasma. It's about 55-45, and that can vary somewhat with individuals, of course. And then the plasma part is water and protein, and then other solutes like the ions, like your potassiums and your calciums, your magnesiums, your nutrients, waste products, gases, regulatory substances, hormones, and all that. And then the protein parts, albumin, globulin, and fibrinogen. What does fibrinogen do? Do y'all know? Has to do with clotting, right? And that albumin and globulin then are that kind of helps us tell if we're well nourished and all too, doesn't it? So, and then that kind of tells you what the percentages can be on here. And I just think that's a neat visual anyway, but it's not something you have to memorize. All right, and I've just got a lot of pictures here, but I just think it's neat to look at it in a lot of different ways. Here's a pluripotent stem cell, so it can be anything, but this means pluripotent in the blood cell column here, and then you've got your committed myeloid stem cell, so it's going to be a white blood cell, or in the myeloid line anyway, and myeloid line includes the red blood cells, so that's not something you have to memorize or anything, but this just shows you all of these are a lot more of the different immature cells before it actually gets to the reticulocyte, and these are the ones, remember, that they can function somewhat and carry some oxygen, and then the erythrocyte, the full function of erythrocyte, is the one without the nucleus, and the nucleus is burst from here to here. But when you start seeing these blast cells, that's not a good thing. If you see blast in somebody's differential or red blood cell blasts, that may not be a good thing. There's something wrong if it's that immature. And if you see blast in white blood cells, that's usually a leukemia signal. So anyway, just know that the reticulocytes are the immature RBCs. I've got that on the notes page, and they may be increased when clients are recovering from anemia. I did have to get on the notes page about polycythemia, didn't I? Is that on your notes page? Poly-sci, that inside means poly means too much. And it actually is called malignancy now. They used to just call it a hematological disorder, but it's actually called a malignant condition now, where the bone marrow produces too many RBCs. And they what do you think if you got too many red blood cells? What's it going to do to your blood? Thicken. It's going to be like syrup. I mean, blood's sort of thick anyway, but if you've got too many red blood cells, it's really, really hard to get through a needle. And then, let's see, we can have poor tissue oxygenation just because of that viscosity, because it's so thick it's hard to get into those little capillaries. So the blood's just so thick you're not going to have that good oxygen exchange. And it causes the red blood cells to have a shorter lifespan and a buildup of the cellular destruction. Your body's trying to get rid of them, which you don't need. And then all those cellular destruction products in the blood, so you may end up being one color. Yellowish, well maybe even just sort of like a bronzy color. Sometimes they have the people with that have just sort of a kind of an odd looking tan sort of color. Because it's a chronic process going on. And then you've got the cell breakdown products can be like uric acid, and so you can end up having gout problems, or it can crystallize in your kidneys and cause problems as well. And then you can have, what is your main intracellular electrolyte? Yeah, I know y'all have that. Potassium. So what can you have? What might you see on your electrolyte panel? Hyperkalemia. Yeah, and what's that going to do to one of your real important muscles in your body?
Exactly.
Yeah, this really is. Absolutely. So, yeah, that's a big deal. And they do use a drug. This is one of the same drugs that we use for sickle cell. And you can use a drug for it. But I don't think that memorize it for that particular thing. I'll come back to it when we talk about sickle cell, and I'll tell you what's the same drug, because I don't want to get you confused over this now. But anyway, what you can do actually is to take blood off, and we had to do that if the medication's not decreasing the production appropriately, then we may just have to take blood off to get rid of some of that volume. And you'd think that we got all these anemic cancer patients. It wouldn't be nice to just hook up one patient to that has the high hemoglobin to the person that's got the low hemoglobin. Well, why do we not want to do that? Well,
Diseases, blood type.
If it is a malignant condition and they are abnormal red blood cells, or they have a smaller lifespan, shorter lifespan, and all that, then you don't want to be giving some cancer patient abnormal red blood cells. So I always wondered about that, when we first started doing it. And it is really, you have to put like when you're donating blood at the Red Cross, you have to have that kind of a needle. You have to get special kits from the hospital lab to be able to actually take the blood out. And it is really, really thick. Sometimes it's so slow trying to get it out, and sometimes you can't even get a whole pint out. You usually take about a pint of blood at a time out, and then it'll lower their hemoglobin a few points, and you'll be able to oxygenate better and all that sort of thing. So, I guess that's about it with the polycythemia. But if you do see that name hydroxyurea, that is one of the drugs that they use for that. But you don't have to remember that right yet. I'll make you learn it later. Okay, I think this is a very cool one too. The causes of anemia, there are really three main causes. So what would be one cause? Blood loss. Yeah, here we go. We can have chronic blood loss. The most common cause of anemia in the United States is slow blood loss through the GI tract. And then, or you can have bleeding ulcers, or you can have colon cancer that can be, more of a bleed than just the chronic slow bleed. And then acute trauma, of course. And what else? Well, you can see, I guess you can see the answers here, but what if you're just not making enough? Or maybe you don't have enough erythropoietin produced. Here's a kidney here. If your kidneys aren't functioning properly, the erythropoietin may not be enough. And you've got to have. I keep talking about the recipes. I always talk about the protonics, and if you can't make the H and the Cl go together, then if your proton pump is inhibiting the hydrogen part of it, then you're not going to make hydrochloric acids, and you don't have everything for your recipe, right? And so you're not going to have enough for you're not going to have all your recipe. Just because you have erythropoietin doesn't mean you can just automatically make red blood cells. You got to have the components. You got to have iron. You got to have vitamin B12, and you got to have folic acid. So if you have deficiencies in any of that, nutritional deficiencies or absorption problems, then that can be an issue too. And then decreased iron availability. If there's a problem with, if you don't have enough stored iron, then that could be a problem with availability too, or the liver's not releasing it properly. And then increased red blood cell destruction. And so that could be hemolysis. Sometimes some medications will do that. Sickle cell disease causes hemolysis. What does lysis mean? We've said that before. But yeah, destruction. It's like what an enzyme does is lyse. It just breaks it apart, tears it up. Okay, so like Aldamet is a blood pressure medicine, or methyl-dopa is one that can cause hemolysis. So you may see hemolysis in some of your side effects of your drugs as you're looking them up in clinical. And if you have an incompatible blood and you have a hypersensitivity reaction, that causes hemolysis because it's recognized that it is non-self. And the immune system tears it up. And then trauma, of course, and a lot of times if it's cardiopulmonary bypass, this trauma to the red blood cells, that not trauma like this trauma, but trauma to the red blood cells that causes them to burst in the process of the bypass surgery. They have to go through some narrow channels and such. So. Let's see what my writing says. What are some symptoms of fatigue? We couldn't read the writing. Yeah, fatigue. We talked about that with the little girl, didn't we? And maybe that's the reason for her fatigue. What else do you see? We can see with vital signs.
Decreased blood sugar.
What y'all think?
Decreased blood
What?
sugar.
Decrease in blood pressure, yeah. What about pulse? The heart's going to try to compensate by pumping blood more frequently to try to speed up that oxygenation and perfusion process.
Respiration.
What'd you say, Jeff?
Respirations will increase.
Yeah, respirations can go up too, because that's right. If you can get more oxygen in, then hopefully the red blood cells that you do have will be able to hook up to that hemoglobin. And then you can now actually have hard murmurs and gallops and decreased pulse pressure. Have y'all learned what pulse pressure is? The difference between the systolic and the diastolic. Right, so if it really comes close together, then that could be one of the reasons too. Okay, and I always get on my soapbox about this, and I said that in your lab interpretation sheet that I did last semester. I don't want you to tell me when you have somebody with low hemoglobin, hematocrit, and red blood cells that it's because of anemia. It's not because of anemia, it is anemia. So what is causing the anemia? Not just calling it anemia, that's not enough to tell. You need to interpret what is going on with your patient that would cause their red blood cells to be low. And it may be one of these things. It may be a lot of times on our unit we have hip fracture patients, and they lose a lot of blood with the injury and with the surgery. And what were you saying? Diabetes, yes, absolutely. So a lot of these things are things you can consider. If their kidneys aren't functioning well, then you can pretty much assume that could be that could be one of the reasons, reasonable, realistic reasons for your patient to have it. Let's see. A lot of times people can just like with the breathing deeper or breathing more frequently and your heart rate going up and that sort of thing, you may not even notice if it's a little gradual blood loss. You may not even notice the symptoms until you go in and have a blood test. That's why with colon cancer, a lot of times people maybe start feeling a little bit tired, but they're just going into the ring of checkup and their hemoglobin is 8. And then they start going, oh, now something's going on here. One of those three things is going on, blood loss or destruction or for the problems with production. So which one is it? So then they start looking for reasons, and a lot of times they'll do like a hemocold test or a colonoscopy or an endoscopy to see if there's some kind of problem with GI. Just because, well, just like Jennifer said, that's very, very common. That is the most common way that people become anemic, and at least in our country. So, okay. Okay, and of course I did just have a sentence at the bottom of the notes page that says that anemia does decrease the oxygen carrying capacity of the blood, which I think we've already covered that. But if there's a rapid blood loss, though, we do have volume problems. If it's a slow blood loss, you can keep replace your volume and all, but it really can cause volume problems and tissue perfusion decrease, and sometimes you can actually, of course, you can bleed to death. You can exsanguinate if you can't keep anything in your blood vessels, or not enough to perfuse any tissues, especially your heart. That's where you just got to have your perfusion for survival. And then I've got some charts on. There's so many charts and tables in your books, and I didn't mean to overwhelm you by posting that other thing. I knew that there were some charts about anemia in that concept book from last year that were real good, talking about like sources of folic acid and what can cause folic acid deficiency and iron deficiency and all those kind of things. And it's just in a little bit different way, and you don't have to even use that. I just did it for another way that you could kind of interpret the what's going on when you got these deficiency anemias, and what kind of care that you need to give to them. I thought that it was organized. That was one thing I really did like about the concept book, that the care charts that they have are the things that you can teach patients. But Iggy has some real good ones too. They're just different. So if you don't want to go into that image one about it was about anemia, I think it was. That's how I named it. But you don't have to do that. You don't have to use it at all if you don't want to. It's just an extra fluff maybe. But if it helps you to understand it, you can just skim through it and see if it'll help you. Okay. Let me just do a few more minutes. What time do you have to go?
I don't know, for another hour.
Oh, okay. So we're good. I didn't know what time the thing started. All right. Oops, I went the wrong way again. Sorry. Boy. There we go. This is gross. I'm sorry, but I actually did find the shark bite picture on the internet, and so that is that you can exsanguinate from something very serious if you got it like in your femoral artery or something like that. That would be a lot more difficult to deal with in that peripheral wound, but that's certainly a way that you can lose volume. So we can have our circulatory volume and our cardiac output decrease, the viscosity decreases, and the fluid shifts to the vascular space. It comes out of the cells and out of the extracellular fluid and goes into the vascular space, so our peripheral tissues are not getting the perfusion that they need. So we got peripheral vasoconstriction, increased heart rate, respiratory rate, and compensation. We've already mentioned all of that, but you do have a risk for shock and circulatory failure and just exsanguination, and death, of course.
How much blood can be lost before they start fasting?
And it varies from person to person, depending on what the people wants to start with, and how fast it's going on, and whether they've got some transfusion started. Sometimes you can just, I think this Walker was telling all about, that person that they were taken from the cafeteria or something and had to go to OR, and they were just pumping blood, and it just went really, really quick with that process. But I think it was a real extensive, believe what. When did I get something, GEO or something? It was a GI thing, but it was really, they just really hit a vascular area. So it really does depend on a lot of things. So probably how warm it is and stuff like that too.
How big the trauma?
How much trauma. It's really variable. But I guess it's Walter could probably tell us about that really fast one there. Because that really, I think that's
I'm just curious, like how many liters of blood can a body run on? I guess is what I'm trying to say. Like if it drops down to 3.
Yeah, and I've seen 4 before. Have y'all seen, how low have y'all seen where somebody is still alive?
My mom said it was 3.
3, so it can, and I have seen 4, but some people would not be able to live with it if they really had, like COPD, like severely or something like that, or have compensatory ways to get their oxygen distribution. So there's so many factors that's involved in it. But, I wouldn't think that you could live very long with 3, could you? They got a lump right back.
Well, they were putting it in as quick as they were putting it in.
But it did.
Yeah, we couldn't figure out.
Do they put ice in? Do they still put ice in lavage or whatever? Ice lavage, lavage. They used to do that. The cold would help to stop the bleeding. Did y'all ever see them use cold? Because I have not had to deal with that in the clinical setting in a long time, but that's what they used to do is get put cold water down the injury. And that would help to get the blood clot. So anyway, yeah. Oh, one thing about that makes me think of it, Joey did. We always hear that George Washington died in Tokyo cornbread or something like that, or complications of long-term syphilis and other things. But what we found out in a museum a few years ago was about a leadership issue or whatever. They had this interesting thing about George Washington for some reason that they used to bleed people. They would cut their blood vessel and put a pan under them and take off like a pint of blood or something. And the time that they were having symptoms of some sort of problem, they felt like the bad humors, they got the bad humors out of their body if they took the blood off. Well, what they ended up saying was that Dr. Benjamin Rush was taking care of George Washington, and he had pneumonia or something. And Dr. Benjamin Rush Medical Center in Chicago is named after him, and I think there's lots of other hospitals too. But he was a famous doctor back in the colonial times and all that. They just didn't know what we know now. But anyway, they said they bled him 9 times. And so if you take a pint out, you're already sick, then if you've got pneumonia, sometimes you can be, get anemic if you have pneumonia while it's making you sick. Sometimes you walk in pneumonia and then it puts you down and you have this long process and you may be anemic to start with. And then they take 9 times, just over and over again. Every time he ran a fever, this fever would go up, they bleed him again. And it's like, so they really think that he exsanguinated because they took all the blood out of him. And I don't know if that's 100% true, but that's what some people are theorizing, that that's how he died. So anyway, okay, so when we have that acute blood loss, that's in your notes page. If there's stored iron in the liver, that's where the iron is mainly stored. It is in some other areas too, but then the red blood cells and hemoglobin and hematocrit can come up faster than if you don't have iron stores. Like we said, when you don't have the ingredients, you can't make the cells as quickly. So, and in that way, though, the circulating cells that are produced and come back into the circulation are normal. If you look at them under the microscope, they have their size and shape. But now if there's chronic blood loss and you start losing your iron stores because your liver's having to just continuously put out a lot of the extra iron that the body is going to need to replace those red blood cells that they're losing through the GI tract or whatever, then they become small and they're called microcytic. Well, that just means little cell, but they it all has to do with cells. So if you've got microcyte, that means it's a little cell. And then they become pale too. And that is called hypochromic. So the chromic is the color part of it. So that it's based on pale. All right, this is a good time to break. Let's come back and neat thing to learn this. All right, let me see if I can go ahead and move this one. Okay. To nutritional anemias. That's kind of an ignorant color, isn't it? It doesn't look that bad on the screen. People wouldn't want to eat looking at that, I guess. But, of course, our production of red blood cells, erythropoiesis, you have to have ingredients. You've got to make the cake, and you've got to get get everything you need to make it. So you got to have your iron, of course, to make your hemoglobin. Got to have proteins and amino acids. You got to have B12 and folate, and you got to have vitamin C and E. And so if you have nutrient deficits because you're not eating well or you don't absorb your nutrients properly, or you have an increased need for nutrients, like if you have an increased metabolic rate or something like that, you may need more nutrients. Or if you're trying to do bodybuilding or something, if that's your goal, then you would need more nutrients. If you're going to really stress your body with all that exercise and everything, you may need the extra nutrients and proteins and all that. Did you have your hand up?
Yeah, I just had a question. Erythropoiesis is the reproduction of the red blood cells?
Yes, it's the actual the production of, the making of the red blood cells. That's exactly what it is. So, you can actually go to my plate and find all kinds of information about blood building foods and for the anemic clients. But those extra image slides that I posted do have a lot of good information in it too. That might be easier to find it there than if you could go on my plate. But my plate certainly does have plenty of resources for that. I think y'all learned that last semester when I made you delve into all that stuff and show me that you knew where to find it and all that kind of thing. So that's certainly a good teaching tool. All right, so iron deficiency is the most common anemia in children and adults, is iron deficiency. And of course, you can have iron deficiency because you've lost blood, because the iron, your body's always going to be recycling the iron, but it might, if you're continuing to lose blood, then you're going to have iron deficiency as well because you're going to lose the iron stores. And then the increased demand for blood production, like you said, and if you don't eat right, or can't eat right, then that can be a problem. And this actually was a slide from your maternal child book, and it was one of the older editions, but it's the same stuff still stands. But adolescent females can tend to be anemic sometimes. Have you heard the term menorrhagia? Mm-hmm. What's that mean? Starting your period? Yeah. It's like a lot of excess menstrual flow, real heavy menstrual flow, where the young lady becomes anemic because they're losing so much blood in the period, or have a period of 4 weeks or continuous periods. And sometimes in your menopause, the women will have a lot of bleeding too, and end up having a hysterectomy because you're becoming so anemic. So, okay. So when we talked about the ulcers and all that, that's the most common way to have the blood loss that can cause the iron stores to get depleted. And in adult females, and along with the adolescent, that's the most common cause for adult females too, is the blood loss from having their menstrual period or a heavy menstrual period. And I think we already talked about that. Okay. Why would you have an increased iron requirements? What's a condition or situation you may find yourself in that you need more iron? Pregnancy, yeah. Did you already take iron during pregnancy? Because they may let all of us do that when I was pregnant with my first child anyway. I know when I was pregnant with Sarah, I took iron, and we had to give the children iron too because they were breastfed, and so they felt like they would get iron deficient if they didn't. I don't know if did they give the babies iron supplements now with breastfeeding? Do y'all know? So it's not.
It's just they take a vitamin.
So it's if you have a problem or whatever. So they just do them outside. So yeah, I didn't think that they did that as a regular, but that was just a routine. You had the drops, you had to get them, and then they hate it, and it tasted horrible, and they stunk like everything, and then they spit it back up. And I could, when we gave it to Tom, you could hear it hit his stomach and bounce right back out. It was like, it was just like it's horrible. And then he had iron stains all over his clothes. I wonder how many kids are working.
Because of iron?
Sometimes children and pregnant women can have cravings for non-food kind of items, and that's called But anyway, that's don't you know little road spring. Maybe their blood would give us iron, but that's not what we're talking about. But anyway, it can be like clay or chalk. Yeah, chalk or like paint, peeled paint, like in housing projects and stuff. If they have paint peeling and that sort of thing. So what might the child get if a child is eating paint that's red? Yeah. And why is that a big deal? Learning problems. Yeah, I bet you're a teacher, aren't you? So you dealt with them from right. And when they had some shipment of some wooden toys from China years ago, and they were like dolly toys or things for toddlers, and they had so if you go to a foreign country, you got to really watch your kids and that they're not eating anything that's painted, because it may not be regulated. Or they buy a little doll or something and give it to a little toddler, and you don't really know if it's got a little paint on it. You got to just be real careful that they don't put something like that in their mouth. Okay, and lead also tends to make the kids anemic. So, and we'll talk about that in a little bit. All right, here is, I think this one's in your book now. I just, well, no, it's not exactly that. I think they have a picture of it, though. Maybe that's in, I think it's in the image thing that I that I posted for you. But anyway, here's that hypochromic, means they're pale. And then that's because there's decreased hemoglobin synthesis, and then they're smaller too. Those cells, they're real pale looking, are smaller than normal as well. So that's that microcytic and hypochromic, and that's what the cells look like with iron deficiency. So you're gonna, what are the symptoms of the anemia, iron deficiency? So it's still the same thing, you know, and pale, your body, your skin looks pale too, or in your mucous membrane. And sometimes you can actually look, if somebody's still on makeup on or something like that, if you can kind of pull their eyelid down, and if it looks real pale in the eyelids, the lower lids, and that could signify anemia also. So anyway, we may have coolly clammy skin if we're real anemic as well. We think about that as being a low blood sugar. It could be low blood sugar, but anemia can do that too as well. And we already talked about the increase in the cardiac output. A lot of this is repetitive, but that's a characteristic of iron deficiency anemia. You actually can have the angina, the chest pain, because why would you think you could have the angina? So the tissue hypoxia, to what? To the coronary arteries are not being able to get it, and then I mentioned the coronary tissues, right. So the tissue perfusion, but the perfusion of the heart muscle itself can be the problem. And actually, when you do stimulate the erythropoietin release of somebody, even if you aren't giving them shots of erythropoietin, the body can get the signal that we need to make a lot more red blood cells. And sometimes you can actually have what symptom in the bone marrow?
Bone pain.
I mean, it's uncomfortable. It can cause
bone pain.
It can cause pain because there are a lot of cells being manufactured at the same time, and they haven't been released into the circulation yet because they're not maturing as quickly as the body would like for them to. So the marrow can become packed. It can do that with white blood cells too. But it can be very, very painful if that happens. But it is more common with white blood cells, but it can happen with red as well. I don't even remember where I read this, if it was in this report, but 2/3 of the adult iron in our bodies is in hemoglobin. 1/3 is in bone marrow, and the spleen, and the liver, and the muscles. So the muscles have the iron stores in there. That is called called iron stores. That 1/3 that's in the Maris clean liver and muscles is the iron stores. That was my scribble. I should have printed that type of page because I just scribbled it down. But the iron stores get depleted first, and then the hemoglobin stores get depleted.
There.
All right. So we've already talked about a lot of those things. You can actually have irritability. So, if I get grumpy, then you're going to have to say, "Oh, Ms. Beaver must be anemic. She must have an iron deficiency." But in the long term, then you can have the clubbing of the nails, like you can have with COPD. Has anybody seen clubbed nails before? I mean, if you ever have a patient in clinical with clubbed nails, ask if the other students can look, because that's not something you see every day, is it? I mean, it's really not, but it really, what does it look like, Teresa? Can you explain it?
The end of their finger is big, or there's like a bump from the...
Yes, it's like if you were to take the finger off and beat somebody over the head with it, you'd have that, like a club. That's what it kind of looks like, isn't it? It kind of pooches out, and it's sort of malformed, isn't it? Bigger than normal. So that's certainly one of the issues. And then growth retardation in children and developmental delay, tachycardia and systolic heart murmur from the decreased blood viscosity makes you have a swish because it's not as thick as it's supposed to be. So. And you can have developmental delay in adults as well, and especially if they may have had the developmental delay because they were anemic as children as well. You actually do lose some. I think I said this a while ago. You lose some of your iron in your feces, even though the body's trying to recycle as much iron as possible. Some is lost. It's eliminated from the body. So you still need a steady iron intake. You need to keep reproducing your iron stores and everything. So we need to do a CBC and check for the low red blood cells and the small red blood cells, and they are malformed also. They're smaller and they don't look the same shape, or they may be different shapes. And then if you have it chronically, you can have brittle fingernails, and they're sort of spoon shaped. They sort of dip in like the fingernails do, and I guess the toenails too. And you can also have chelosis, and I don't know why they have to have such complicated words, but it means that the corner of your mouth is cracked. You ever drool at night and you sleep in the same position for a long time? You wake up in the morning and you got a sore in the corner of your mouth, or that. That's what you should But really, I was up like 40 and you can have a smooth tongue, and it can be very, very sensitive. Really sensitive. And then the pica, of course, was that. And then here is some. It wants to go sometime. There we go. The best source is lean red meat, and you can also have it in. There's also iron in chicken and turkey and eggs and cereals. And the organ meats, like if you got chicken livers and gizzards and stuff like that, it would have more iron in it as well. But eggs definitely have. The egg yolks have lots of iron in it. Okay, this is so highlight or circle or star or something. That first thing in the notes page, iron absorption is enhanced by vitamin C. Ascorbic acid. See it that way, ascorbic acid. And inhibited by tea and coffee. And it also, there are some other recommendations without it. I don't want to give it all away because it's in there on the test, but you shouldn't take it with milk usually, because that can be a good thing because it can increase the absorption of it as well. And so I think what else I put on there was about, there's some other sources of it. The kidney beans and they look like they have iron in them, don't they? Kidney beans do look like that. They kind of look like blood, don't they? But they're really good for you with fiber and all that. But they've got an iron that's an iron source as well. Is your question? Yes. What else blocks the absorption of iron?
Calcium from
Yeah, you don't want to take calcium and stuff with it in as well, right? And there's some of that in those images, I'm pretty sure, too, some more in the list. Because I don't think Iggy gave quite as good a list as the Pearson book did, so you really may want to look at that. And definitely do your HESI, too, because it gives you some lots of details on all of that, too. Leafy green vegetables, the darker the better, the more iron it's got in it. My dad says it looks like you just clipped your shrubs or something and ate every leaf on the shrubs and all that. Real lettuce is iceberg lettuce. Well, that's pretty much just nutritionally inert. It's got fiber and water, and that's about it. And little bit green, which is pale. So the paler the lettuce, the less and then raisins and blackstrap molasses.
Iceberg is more better than romaine. I've never had a good romaine.
Blackstrap molasses, I don't know what it is that's different about blackstrap molasses. It can't take any molasses, but it's something about that. It has maybe they cook it in an iron skillet or something. I don't know, an iron pot. But it does have iron in it, blackstrap molasses. So that would be like a tasty way if you don't want to eat liver and all that. And then if you actually cook in an iron skillet, the Red Cross told me that when I was I just graduated from college and I started giving blood like at the Red Cross every 2 months as soon as I could. And then one time when they put my drop of blood in that copper sulfate and it didn't sink, and they said, okay, if you think your blood's your hematocrit, it's going to be too low. And when you're a menstruating female, you probably shouldn't be given every 2 months like that. And I found it out and at a real good level. But anyway, they told me to cook it, and I put it in an iron skillet. So make gravy in an iron skillet. Make your grilled cheese in an iron skillet. Make your eggs in an iron skillet, whatever, and that you do get some iron from it. The other thing too is you do have fortified foods that are fortified with iron. A lot of cereals are. Have y'all seen like Total? And I don't know. I guess they still have Total. Yeah, and some of the Product 19 used to have a lot of stuff like that, and I'm sure there are others too. But you can look at your food label. Didn't Dawn talk to you about looking at food labels for the sugar stuff and all that? But you can certainly see, whether it's fortified with iron, and a lot of breads and cereals are fortified with iron. So if you have, teach your patients to look at those labels and see about the iron fortification. Well, my kids and I went to at Horizon, so we did near Knox Middle School for like it was sort of just a wizard sort of presentation, and the guy goes up there and puts some fortified cereal in a blender and turns it all up to powder. And then he takes this great big horseshoe magnet and sticks it in there, and there's all these little fine iron fibers sticking to the magnet. I mean, you could, and we all saw it. He passed it around and walked around and let us all see the little fine iron fibers. It's really got iron fibers in it, and that's what happens with your iron skillet thing too. It does, just gradually wear away into your food, and that's not a good thing with EPA. But iron is a good thing to have in your stomach. We don't want Tupperware in our stomach either, but microwave and stuff. So the iron skillet is a good thing. So, only 5 to 10% of what we eat, the iron that we eat, is absorbed. So, you may end up, if you are a menstruating woman and can't get enough from the iron skillet, it goes back up. What's one of the supplements that you use? I know some of my students have given
Ferrous.
Supplement. What's the oral one, the common one?
Ferrous sulfate.
325, yeah, remember that. There's the iron sulfate, FeSO4, but it's our ferrous sulfate. And it's usually 325 milligrams. Jennifer's right, and that's a real common one. And the Iggy book says that it's best to take it like in between meals for the best absorption. And and the least GI distress. But some of the formulations, the plain iron sulfate, that's probably the best way to do it. But I had Hematology, and it was a coated pill when I was pregnant, and it was Hematology F. And you didn't have those restrictions because it was coated and it would absorb your intestines and everything down, or it was absorbed later on. So some supplements you just need to look at your directions for the paracetamol is less effective. You can take it with your food. So anyway, if you have to give, if you have a real severe iron deficiency, it can be given IV or IM. If you do it IV, there is you have to really observe the patient. What do you think might happen with IV iron? What's that? Say it loud. Well, it just is. It is something that people can have reactions to, and that you do have to watch them really, really closely to for the IV kind. And you can actually do it IM as well, and that's where you really got to do a Z-track.
So the book recommended, or so most manufacturers have to see this is
The dorsogluteal, I know, and I'm just like, I'm not doing that. I don't know, I do not do it. You can do Z-track or ventricle, and that's one thing I don't think. And you're going to have to make your nursing judgment about that, because the manufacturer does say that, and they try to do this disclaimer. You know, we know the ventrogluteal is recommended as best practice for any IM or Z-track injection, but or deep one especially, but the manufacturer still is saying dorsogluteal. And I wonder if they just haven't spent the money to do the research because it's generic or something, or that they maybe don't have money for research and development, and that's the only reason because they don't have data. I just can't think of it. Well, I think if I had to do it, I think I actually have been official to tell you the truth, but in the office before. Because I don't like that landmark or that dorso. That's huge. So y'all have to make your judgment on that. So they talk to, if you have to do it in clinical, talk to your instructor about it, and y'all figure out what's going to be the best decision here. Okay. All right, here we go. We're going to switch over B12. You have to have it for DNA synthesis. And it's mainly in foods derived from animals. So who might be deficient in B12 from their vegetarians? Exactly. So if you can't absorb the B12, it's called pernicious anemia, and that means that you do not have intrinsic factor. We'll talk about that again in a minute. And you can also have a decreased B12 intake, which would be the vegetarians possibly. And I had added this to the slide, I think, last year because people were seeing this on their Kaplan tests and were concerned about it being on the NCLEX too. So this actually is a 24-hour urine collection, and you can look in your lab book and get more information on it too. But 24-hour urine collection, it determines whether the deficiency in the B12 is due to lack of the intrinsic factor versus whether there's other malabsorption disorders. So you can certainly look for more details on that if you would like to. But anyway, the deficiency in the B12 does impair cell division and the maturation of the cell nucleus, and it's because it affects the folic acid, and folic acid is really what determines the DNA synthesis. But the folic acid can't work without B12. So that's the deal there. Okay, so the intrinsic factor that's on your notes page. Then it actually is secreted by the gastric mucosa to help the absorption of the B12, and it's actually in the small intestine, but it's in the farthest section of the small intestine, which is what's the section? Duodenum and jejunum, and what's the last one? Ileum. So it's actually in the ileum. So if you don't have an intrinsic factor, you cannot absorb it to B12. You have to have the intrinsic factor. So what kind of problems could people have that might keep them from being able to produce that intrinsic factor? Or absorb the B12 too. Yeah, if you have inflammatory bowel disease of any sort, yeah, the Crohn's could cause a decrease in absorption because you've got all that inflammation in there. Yes, inflammatory conditions and what about surgeries that you remove certain portions? If you remove the ileum, where's it going to absorb from? Even if you do produce the intrinsic factor, is if the ileum is gone, then you might not be able to absorb. So you might have to just take supplements for the rest of your life. And then the chronic gastritis, or if you had they used to do more invasive surgery with those gastric staplings and things like that, the bariatric surgery they call it now. In those first ones that they started doing a long time ago, that's when I first got out of nursing school. It was still experimental doing bariatric surgery. They actually stapled the stomach, and if you don't have as much gastric mucosa to be producing the intrinsic factor, then that could decrease your ability to absorb B12 as well. And then, like Teresa said, you get the diverticulitis in particular when it's inflamed. What's that? Yeah, ulcerative colitis and the Crohn's disease, and anything that would cause chronic diarrhea. Tapeworms, overgrowth of intestinal bacteria, anything that would cause inflammation to where that mucosa is not intact. So the dietary deficiencies of B12 are really, really rare except in the vegetarian, so it's not something that you're going to see so often. But what happens is that your stores get depleted, but B vitamins are they fat soluble or water soluble? Water. Yeah, so it's not gonna stay stored very long, is it? I mean, it's not gonna be something that you're gonna be able to keep in your body any length of time. You need to just keep them having an intake on it. So, but you actually get a smooth tongue with this too as well. That's where it gets really tricky because we have some of the same symptoms with iron deficiency and with B12. And the diarrhea can actually be a manifestation of the B12 deficiency. But the big distinguishing factor here is that it is really essential to nerve function. And so people, have you ever heard of paresthesias, like tingling or pinprick feeling in their fingers or toes? And you can have, I've seen it so much in patients with certain chemotherapy drugs, or it starts with peripheral neuropathy, but it may not be numbness. It could be numbness, but it's a lot of times starts with just like it's just falling asleep, and you've got that pinprick feeling in your fingers. So that's definitely a symptom. So that distinguishes from folic acid and iron deficiency anemia. That is the distinguishing factor, is that it affects the nerve function. So, and then you can actually have a developed problem of balance too, in the proprioception, like when you're I guess like with that raw bird, and you're doing closing your eyes and all that sort of thing, and to be able to like tell what your position is in space, sort of thing, that proprioception. And that may be, which patient stepped off the curb and couldn't tell that they were, I don't remember whose patient was that yours? Yeah. And I just wonder if it had something, if there's anything to do with that, it may be some kind of big thing, or but at least that is sort of a proprioception thing. You're not really sensing where you are in place at that particular time. But it could be a visual perception thing too. What's that? Yes, that's right. Yeah, you're right. So that may be part of it. His patient had a pelvic fracture, so you can't do an operation on that, and has to go on bed rest for 4 to 6 weeks and then go on rehab. And that's really tough stuff. But also the balance in it, you got to be really careful. It can definitely be a safety issue, risk for falls and all that if somebody has B12 deficiency. And if you discover it within or diagnose it within 6 months of the onset of the deficiency, then if you start giving supplements, you can usually get all of the nerve function back. But if it is more than 6 months, and of course that can vary from person to person, then they may be permanent symptoms, and they have that permanent balance problem and all, and that's really bad news. So, keep going the wrong way, I'm sorry. Vitamin B12 food sources. I just love these pictures. I don't remember. I got those off the internet somewhere. So we got some of the. This is you know, the animal products, the meats and eggs and dairy is our big B12 sources. So. And I think I got this from Iggy, but the deficiency of vitamin B12 prevents the activation of an enzyme that moves the folic acid into the cell, which inhibits DNA synthesis. The deficiency inhibits the DNA synthesis. So these abnormal RBCs that are large, they are macrocytic. So they are large cells when you have vitamin B12 deficiency. So, and they are misshapen. They're not biconcave. They're oval and they're not biconcave, so they can't perfuse as well either when there's a deficiency. And that's probably what affects the nerves, is they're not getting the perfusion that they need. And they become more fragile, and the membranes become real thin, so they don't have as long a lifespan either, so they don't get enough oxygen to the tissues. So the hypoxia of the tissues and perfusion can definitely suffer. And you can definitely do vitamin supplements for B12 anemia. You can take it orally, but it does absorb better if you take it subcutaneously. So, and what they normally do, if you do need supplementation and you're having the symptoms of nerve symptoms in particular, you would be taking shots weekly for about a month, and then monthly for your daytime. If you don't have the intrinsic factor, then you can't fix the condition that causes the loss of intrinsic factor. So they do have a nasal spray called Calonist, C-A-L-O-N-I-S-T, that could replace the monthly injections in some patients if they are eligible, if they don't have sinus problems. There we go. That's an awful coloring again. Yeah. All right, but again, that is definitely required for the DNA synthesis and the RBC maturation. So when people are chronically undernourished, like older adults that just don't eat properly at all, alcoholics. How many people have had an alcoholic patient and have had to give folic acid? When you see folic acid on there, that's kind of like, that kind of gets to be this like flag that, you know, I wonder if this patient's alcoholic, you know, and usually you go to their history and that's why they're on it. So, and then pregnant women are at risk because of increased folic acid needs, and then malabsorption disorders like the Crohn's and the celiac sprue, which is the gluten issue, and then some medications, methotrexate and other chemotherapy drugs. That's how they work, is to inhibit the folate from letting the DNA synthesis go on in the cancer cells. So that's the way it works, is to, and it can be poison in one way, but then it can be therapeutic if you're needed to decrease DNA synthesis on the cancer cells. And then anticonvulsants like I guess like what are some of them that y'all? Yeah, Delanton is one, with some other ones. What's that one that starts with a T? I can't think of it.
The Tegretol?
Whatever. Yeah, Tegretol. Yeah. I keep having all these intellectual interludes about the names of stuff. It'll come to me eventually, but probably not when I'm in front of y'all. But anyway, oral contraceptives sometimes can slow or prevent the absorption of the folic acid too. So that can be an issue. And then this is usually a gradual depletion also, and it can also cause the paleness and the weakness and the fatigue and shortness of breath, heart palpitations, irritated tongue. See, all of the anemias cause irritated tongue, so you can't really distinguish it that way. And you can also get the sores in the corner of your mouth and diarrhea, but unlike the B12, you don't have any neuro symptoms with folic acid deficiency, not the paresthesias or the numbness of tingling or the balance problems, none of that. But you can have both of them at the same time. If you're malnourished, you're probably not getting the folic acid or the B12, so, or the iron even. But the maternal folic acid deficiency is really, really, really a big deal, because a lot of times people don't even know that they're pregnant before the spinal column is kind of closes, is supposed to close up, And that's what the folic acid deficiency can do, is they call it the neural tube. It causes neural tube defects, which is like spina bifida and meningomyelocele and all that, where the spine hasn't closed up properly, and the babies can be defibrilized or have valve bladder control and that sort of thing. So it's really, really, really important that women in childbearing years have enough folic acid, because it really are in childbearing years, and you could become pregnant, you certainly want to be well nourished and make sure that you're getting folic acid, because you don't want to have to inflict that on your child. Okay. Really, the folic acid supplements orally are the best way. You don't have to do the injections or anything like this kind. And then the dietary interventions to make sure it eat properly. And I did that by accident. Okay, folic acid sources. Isn't that pretty? We've got our green peppers and our fruits, and got some fruits and vegetables and all of that. And again, that image thing has a lot about folic acid and B12 and some other ones that we haven't mentioned. These are just some of the most common ones. So, but those are some good ones. And it's liver and yeast and dried beans and nuts. And you don't really see that there, I don't think. Liver, yeast, dried beans, and nuts. I don't see any of that deal in there. But that was on another list that I saw as well. This other stuff is really not your exemplars, but it's something that we want you to be aware of. Actually, sickle cell is a hemolytic anemia, but we're not going to go into that. I told you on your reading to stop that sickle cell in those areas. It's kind of choppy the way we're doing it, but we're not covering that exemplar until 211 maybe. But anyway, it is premature destruction of the red blood cells. We talked about the lysis to break something down. And it can be a problem with the RBC itself. It can be defective. The structure of the hemoglobin may be a product, and it could be something that's inherited that can cause the destruction of the red blood cells. But things that can happen from the outside, like medications, some kind of toxins, like the snake venom. I just wonder what exactly made that creature die from the snake venom exactly. If he had hemolysis or something. I made me think about that when I saw the snake venom thing. Like, oh my gosh, because he got bit by a rattlesnake. He was that snake handler and preacher, and got bit, and he didn't want to go to the hospital, and then they found him dead later, and so you wonder what exactly did happen to him. Because venom can do other things too, but I wonder if that hemolysis was part of it. And then trauma, like we said, especially like if you're having open heart surgery or something like that. Where was the accident? There was Laura's patient. He had an anaphylactic reaction to ACE. Wow. So actually, it has venom in it. Oh, wow. Well, Ms. Russell I've been telling my clinical groups about this, and I asked Ms. Russell why ACE inhibitors cause the cough, and what actually is the mechanism. Did they talk to you all about that? Well, she's been working in cardiac for a long time, so she's started doing education. And I asked her a few weeks ago, and I said, what exactly is the physiological reason for that dry cough? And she said that in the process of inhibiting the transition or the conversion from angiotensin 1 to angiotensin 2, it actually leaves some free bradykinin, which is an inflammatory mediator. It's an inflammation like prostaglandins and histamine and all that. And so that's why you can have angioedema too. But I wonder if the snake venom is a part, like what keeps it from converting. And I bet that's it. I bet the snake venom is the key ingredient that keeps it from converting. But then you've got that bradykinin there, and so you can have angioedema, or you can just have inflammation that just makes you have a dry, itchy cough. That's what she said. it's a bradytron, it's a substance, but I bet it came from snakes. I don't know. I went to find out. I have to ask her that because she's really full of information about all that stuff. So that's really cool. Okay, I'm going to get my act together with this thing here. I really like the other kind where you just have the arrow. All right, this thalassemia is not one of your exemplars that you have to memorize, but you're probably going to see it on a Kaplan or something. The thing I want you to know about this is that it is, in certain populations, it is a hereditary disorder. And you can have, if you have the major form of it, you actually can have a shortened lifespan. But some people do fine with the thalassemia minor, and that's not a big issue. But the big thing to identify thalassemia is that when you look under the microscope, it looks like the cell looks like a bullseye, and that's the real factor that you can say that distinguishes it. So just know that it's hereditary and that the cell looks like a target, a bullseye. So they call it target cells. If you see that on a CBC, that's where that's what distinguishes it from other diseases. And then if it can, with the hemolysis, since it's a hemolytic anemia in the major form, you can have the jaundice just like you would in other breakdowns of red blood cells. And if you do have to have a whole lot of blood transfusions, the extra iron that your body starts storing can become toxic to you and cause heart and liver and pancreatic failure, organ failure. But that can happen with anybody that gets a lot of transfusions. They're all weighing in, so my thumb is just not doing the right study. Okay. And we talked about the mechanical trauma, and you can have autoimmune disorders that can break up the red blood cells too. Some kinds of bacterial infections and protozoal infections can cause them to break down. Immune system mediated responses, just like breakdown of the red blood cells when you have a blood mismatch or have a blood transfusion reaction, and drugs and toxins and chemical agents in the venoms we said, and it depends on how well the body can replace the RBCs, or if it's a chronic thing. If it's just an acute thing, that the body will probably get over that. But if it's chronic, then that may not be such a big deal. And do look at your med side effects as far as hemolysis, though. That's definitely a biggie. Okay, and this other one is glucose 6-phosphate dehydrogenase. That's a really tough one to say too, but. Okay, it is hereditary defect, and it's African Mediterranean descent, and it is an enzyme that catalyzes the glycolysis and normally produces energy for the RBC. So this has to do with all that, I guess, that Krebs cycle stuff that's so hard, but it does have to do with metabolism of the sugar. But the hemolysis happens when a person gets stressed, and symptoms can happen within just a few days. And then when the stressor is over, then the new red blood cells can replace, and then the blood counts can come back to normal. So they're not just sick all the time with that. But that's another hereditary one that has to do with metabolism with the glycolysis. And acquired hemolytic anemia is when sorry. I just went too far. There. Gosh, my thumb is it just does not do that fine tuning. That's why I can't text, I guess. I do terrible texting because my thumbs are just clumsy. Okay, aplastic anemia is another thing you might see on Kaplan or NCLEX. It means bone marrow failure, pretty much. What does A mean in front of something? Just none. And I think it's kind of funny though that they call anemia anemia, because that means none too, doesn't it? It really isn't none. I guess when they came up with the term, they thought it was none, but it's really just less. But it doesn't mean you don't have any blood. I guess you could just have no blood, but it means little or none. But that means you're not manufacturing any of the blood cells if it's aplastic. That's called pancytopenia. Pan means like everything. So it's not producing red, white, or platelets. So that's pancytopenia. And we know about penia means what? Lack. Yeah. And so it can be congenital or acquired, and symptoms are related to how bad the bone marrow failure is. And the marrow can be replaced by fat, and so it's not doing what it's supposed to do, no matter what kind of stimuli, the erythropoietin or whatever. It's not gonna be able to produce. But you can, of course, have infection and fever and fatigue and tachycardia, all those symptoms that can happen when you have a lack of any of those cells. And you can, with congenital, when you're born with it, you really have to have a bone marrow transplant. It's really the only way to fix it, and it is a poor prognosis. But when it's an acquired, it could be from like long-term exposure to toxic agents, and like ionizing radiation, or like radon or something like that. If you have your house is near radon or something like that, or if you've had a long-term infection that caused, or if you had sepsis that really caused a lot of toxins to be in your blood, then they don't really even know what causes about 50% of these cases. It just happened, and we don't really know why. But with acquired, you sometimes can take immunosuppressant therapy, like Imuran or like cyclophosphamide or something like that. And then bone marrow transplant is an option too. I don't know. I don't think I told y'all this, but when I was working with Dr. Black's office, and I was pretty young, man. I think I was less than 30 anyway. But we had this student from Catalda. He was an athlete. I don't remember if he played football, but he was a sports person. I mean, he's real broad and muscular, and you could tell he really worked out and all that. And he came in with the pancytopenia. And so had a bone marrow test, and it did show that he wasn't producing the cells. I mean, he had the aplastic anemia. And so the only thing that they could do for him, I guess they figured that it was one of those that something turned on the congenital problem or something. I don't know, or maybe they had already tried to give him something and it didn't work. But they went ahead, and since he was really healthy at that point, when they did a bone marrow transplant, and he died because bone marrow transplants are really, really toxic. They try to kill all of your blood producing capacity with radiation and chemotherapy, and then they give you a transplant with a matched donor. But I don't remember what his complications were, but he ended up dying. He was just like 20 years old. It was just like, that's the saddest thing. I mean, good looking, like an advertisement, whatever. And, just like a model. He was just a gorgeous guy. It was just, not that you wouldn't want other people to be successful or whatever. It's just like he just had everything going for him, and yes, it's just not fair sometimes. Not fair. Okay, and then this just tells you some things about children with anemia, so you can just read over that. And then I put the cook in the iron skillet, and then neonatal anemia. This just tells what can happen, like the RH factor issue, and mothers have to take the RhoGAM after they have a baby that's RH positive, and the mother's RH negative, and they can have the blue babies. They have a lot more interventions with that now, but that used to be a big deal. They used to have to replace the baby's blood a long time ago. People my age, if the mother was RH negative and the baby was positive, then there's y'all listen. This is important because you're probably going to need to know this. This award's probably going to teach you some of this in the summer, but you can't live with all your RBCs being destroyed like that, and so they would actually replace the blood with compatible blood, and then take the baby's blood out and totally replace it because they were blue. They weren't being able to oxygenate. So anyway, you can just read those last few slides. There's not a whole lot else on there that you can't just read. So I just wanted you to be exposed to those last few slides, even though they're not the important exemplars are the iron deficiency, folic acid deficiency, and B12 deficiency. That's our main focus. All right.